Go.
Hi, so I'm Dr. Rakshit Yadav, and the topic of my presentation is brainstem syndromes. So, brainstem syndromes are basically a subtype of stroke. So, they are caused by vascular injury to the vessels supplying different parts of the brainstem, and they are classified according to the part of brainstem involved. So, these syndromes can occur due to ischemic or a hemorrhagic kind of insult. And ischemic strokes are far more common than hemorrhagic strokes. So the brain stem is the lower part of your brain that connects the spinal cord to the rest of the brain and plays a crucial role in controlling vital functions such as breathing, heart rate, blood pressure, even your sensory and motor functions. So damage to different regions of the brainstem can lead to distinct patterns of the symptoms. So this is just an image of the brainstem, and the areas we should focus on are the midbrain, pons, and medulla. So I'll just give a structure overview. So the first part we should focus on is the midbrain, also known as the mesencephalon. So the midbrain is the uppermost part of the brainstem, and it kind of serves as a bridge between the lower brainstem and higher brain regions. So the important points of the midbrain functions are visual and auditory processing. It also contains structures involved in regulating arousal, attention, and even sleep-wake cycles. It also helps in controlling eye movements and pupil dilation as well. Now, the second one we should focus on is the pons. Now, pons is situated above the medulla oblongata, and it contains several important motor nerve nuclei, some sensory nuclei, and it basically contributes to facial movement, hearing, and various other functions. Then we have the medulla oblongata. So the medulla is the lowest part of the brainstem, transitions into the spinal cord. So it plays a crucial role in controlling vital functions such as breathing, heart rate, blood pressure, and even digestion. So it also contains nuclei that regulate reflexes, such as coughing, sneezing, or swallowing. So this is involved in sensory and motor information between the brain and spinal cord. This is just a broad diagram for vascular structures. I'm going to explain each of the vascular structures separately according to the subparts of the brainstem. So first one is the midbrain. So midbrain should be divided into four arterial territories. And I have given these areas separately. So first one is anteromedial. This is supplied by the posterior cerebral artery. And posterior cerebral artery is usually associated with midbrain strokes or any kind of insult. Then you have the anterolateral areas as well. So this is also supplied from the posterior cerebral artery or a branch of the anterior choroidal artery as well. Then we have the lateral area of the midbrain. This is supplied with the posterior cerebellar arteries, not the cerebral arteries. And then the posterior group of the midbrain is supplied from the from the superior cerebellar, collicular, and posterior medial choroidal artery. Then we have the pons, and usually the most common patients are seen. They usually have an insult to the pons. So this is a really important diagram as well. So we can see here that the anteromedial region is supplied by the perforating arteries of the basilar artery. And the anterolateral area is supplied by the anterior inferior cerebellar artery. Now, the lateral zone is supplied by the perforators of basilar artery as well as the anterior inferior cerebellar artery or from the superior cerebellar artery as well. So this is extremely important. Then you have the medulla, and medulla is again divided into four areas. And you have anteromedial first, which is supplied by the anterior spinal artery and the vertebral artery. Then you have the anterolateral area, which is supplied by the anterior spinal artery and vertebral artery again. The lateral area is supplied by the posterior inferior cerebellar artery, and the posterior area is supplied by the posterior spinal artery. Now, this is a really important topic, the rules of four. So these rules of four explain us how should we tackle a patient that comes in with a brainstem syndrome. This is very essential for clinical diagnosis in these kinds of patients. So rule number one, this is that there are four cranial nerves above the pons, including two from the midbrain, and then four at the level of the pons, and then four from the medulla. So four. So I'll just broadly categorize these cranial nerves for you. First one was optic, Then it was olfactory, oculomotor, and trochlear. This was supposed to be above the pons. Then four inside the pons are your trigeminal, your abducens, your facial, and your vestibular ochlea. Then the four in the medulla are your glossopharyngeal, vagus, spinal accessory, and hypoglossal. I hope I'm clear. Then the second rule is the four cranial nerve motor nuclei that are in the midline, actually the paramedian nuclei, are those that divide equally, except the cranial nerve 1 and 2. So the four midline motor nuclei are third, fourth, sixth, and 12th. Third is your oculomotor, fourth is your trochlea, sixth is your abducens, and 12th is your hypoglossal. In the lateral motor nuclei consist of the fifth cranial nerve, seventh, ninth, 10th, and your 11th. And there are no motor nuclei in the cranial nerves 1, 2nd, and 8th. That is your vestibular cochlea. So these are two rules of among the four. Now, the third rule is really important. This says that the four midline structures in the brainstem begin with M. This is kind of important for us to remember. So, motor pathway, that is the corticospinal tract involvement, leads to contralateral loss of power of the limbs. Then you have the medial lemniscus. Involvement of the medial lemniscus leads to contralateral loss of vibration proprioception of the limbs. Then you have the medial longitudinal fasciculus. So, this tract is involved in internuclear ophthalmoplegia. And then you have the motor nucleus. So motor nucleus is involved in your the motor nucleus of four cranial nerves are present in the midline. So the oculomotor, the trochlea, the abducens, and the hypoglossal. So these nuclei are affected depending on the level of the brainstem. Then the fourth rule says that there are four side or lateral structures beginning with S. So the first one is spinocerebellar pathway. This is basically the extension of the spinocerebellar tract. And involvement of this leads to ipsilateral ataxia of the limbs. Then you have the spinothalamic pathway, and this is extension of the lateral spinothalamic tract. So obviously it leads to contralateral loss of pain and temperature affecting the limbs. And then you have the sensory nucleus. This is the nucleus of the trigeminal nerve. So involvement of this nucleus leads to ipsilateral loss of pain and temperature only on the face. That is in the distribution of the trigeminal nerve. And then you have the sympathetic pathway, and lesion in the sympathetic pathway usually leads to ipsilateral Horner syndrome. So I have an example for you. So this is a patient that comes in with Horner syndrome on the right side of his face. There is ataxia on the right side of his body. There is loss of facial sensation also on the right side of the body. So there is loss of pain and temperature on the contralateral side, and then there is dysarthria and dysphagia on the ipsilateral side again. So by using the rule of 4 that we just studied, loss of blood supply should be to the posterior inferior cerebellar artery. So this syndrome is also called as the Wallenberg syndrome or the lateral medullary syndrome. Now we'll see the signs and then try to associate it with the rule of 4. So you have first the ipsilateral Horner syndrome. So sympathetic pathways are always present on the lateral side, as we read in rule number 4. Here is this. So sympathetic pathway involvement leads to ipsilateral Horner syndrome. Then you have ipsilateral ataxia due to spinocerebellar pathway, and spinocerebellar pathways were also again in the lateral side. So hence the name lateral medullary syndrome. Then you have ipsilateral loss of facial sensation due to trigeminal nucleus, which extends to the medulla laterally. So the trigeminal nucleus has a very broad extension. It can extend from your pons to the medulla as well. So even in lateral pontine syndrome and in lateral medullary syndrome, your trigeminal nucleus is affected, also known as the spinal nucleus. Then you have contralateral loss of pain and temperature due to spinothalamic involvement, again present in the lateral part of the medulla. Then obviously you have dysarthria, dysphagia due to cranial nerve 9th and 10th. This is again lateral cranial nerve nuclei present in the medulla. So this was just an example. Now I'll classify all the syndromes for you. So first one is the Weber syndrome. This is a part of midbrain syndrome. So Weber syndrome, the area of brain affected is base of the midbrain, and the artery involved is posterior cerebral artery, as we just studied. So clinical features of Weber syndrome are ipsilateral third cranial nerve, lower motor neuron palsy. So there is contralateral upper motor neuron hemiplegia as well. This is kind of the differentiating feature between Weber's and Claude's. In Claude's, there is also involvement of the posterior cerebral artery, and clinical features are just same as the Weber syndrome. There is ipsilateral third cranial nerve involvement, but the differentiating feature is contralateral ataxia seen in Claude's, whereas in Weber's, it was contralateral upper motor neuron hemiplegia. So now we have the dorsal midbrain syndromes, and this is really important. This is a very common kind of an example, Parinod syndrome. The most common cause of Parinod syndrome is penioloma that compresses the tectum of your midbrain. So there are very interesting clinical features in this case. There is vertical gaze palsy. So the patient is always looking down. The patient cannot look upwards. There is your overactive levator palpebral superioris. So there is lid retraction in the patient. There is light near dissociation because of the third cranial nerve involvement. So accommodation reflex is present, but the pupillary reflex is absent. Then you have convergence retraction nystagmus as well. Then you have Nathan-Angle syndrome. This is part of your dorsal midbrain syndromes only. This can have all the features of the Parinod syndrome, but the differentiating feature between Parinod and Nathan-Angle is your ipsilateral third cranial nerve palsy. And also there is ataxia in the patient. So this is how you differentiate between Parinod and a Nathan-Angle syndrome. Then you have your Pontine syndromes. So Pontine syndromes can be divided again into ventral, dorsal, and lateral lesions. So your ventral pontine lesion is also known as the Maillard-Gubler syndrome. This has ipsilateral facial nerve palsy because your seventh nerve falls into the pons. And you have your ipsilateral abducens nerve palsy. Again, the sixth cranial nerve is a part of the pons. Then you have contralateral hemiplegia. The mnemonic is FSH. F for facial nerve, S for your spine thalamic. I'm sorry, S is for your sixth nerve, and H is for hemiplegia. Then you have dorsal pontine lesion, also known as the Foville syndrome. This is present on the medial part of your pons. So there is ipsilateral facial nerve palsy again. There is gaze palsy. This is the differentiating feature. Then you have contralateral hemiplegia, same as ventral pontine lesions. And then this is the most important brainstem syndrome related to the pons. This is your locked-in syndrome. So patient presentation is usually that the patient is conscious and awake, but he has no ability to produce movements in any of his limbs. So there is major involvement of pons in these kind of syndromes, but there can be some involvement of medulla and the midbrain as well. The artery involved in locked-in syndrome is the basilar artery, and the clinical features seen in the patient are quadriplegia. Then you have loss of voluntary facial, tongue, and even mouth movements, but blinking will always be present in this patient. So you might think the patient is all right according to the family members because they always argue that my patient is blinking, so he must be all right. There is no need for any further evaluation. But you cannot confuse yourself due to this blinking aspect. Then there is loss of horizontal eye movements. I'm sorry, sir, I'm not kind of ready right now, I think. Because can we stop this?
Want to stop it?
Yes, sir.
Okay.